Hello doctors, my name is Dr. Seth Evans and I'm a practicing otolaryngologist in the Austin, Texas area. So you're probably watching this video because one of your patients asked you to come check it out. I'd like to share with you a little bit about something called the reset treatment, which is basically my name for an endoscopic sphenopalatine ganglion block. I call it the reset treatment because it's easier for everyone to say and it's easier for my patients to remember. So I'm presuming someone has come to you and asked you to either perform this treatment or if you offer it. So I'd like to share a little bit of my experience to hopefully help you decide if this is something you want to offer your own patients. So who is this video for? So it's really for either otolaryngologists or another specialist who is fully trained and comfortable with performing nasal endoscopy. So if that's you, please continue watching. Who are candidates for this treatment? So it's really anybody with a chronic headache syndrome. So migraine patients are probably the most common, and I would think anyone who's getting a migraine more than once a week is probably a reasonable candidate to think about this procedure. Also, patients with cluster headaches, trigeminal neuralgia, atypical facial pain, or other facial and neck pain syndromes would all be reasonable candidates to try this. So the procedure itself is a sphenopalatine ganglion block, and I use a nasal endoscope in order to perform the treatment. So for billing purposes, I'm billing a nasal endoscopy, which is CPT 31231, and then I'm also billing the sphenopalatine block code, which is 64505. So you'll have to see with your own local insurers as to coverage, but here in Texas we've not had much problem with coverage for migraines and headaches specifically. So with the treatment, here's how I do it. So I'm going to be using a rigid 0-degree nasal endoscope. And the prep beforehand is going to be the same as you would normally do for any nasal endoscopy. So whatever you typically do is fine. So once that decongestant and local anesthesia have taken effect, you're going to position the patient. And they're going to be supine on their back, and they're going to have their neck fully extended. So chin up as much as possible. And that's going to be the positioning for the procedure. At that point, you're just going to go in like any normal nasal endoscopy with your scope, and we're going to inject some 2% plain lidocaine into the posterior nasal cavity. So what I use for that is just a 1 cc tuberculin syringe full of 1 ml of 2% lidocaine, and then we're going to inject it through a 2-inch angiocath sheath. So no needle, just the sheath. So we're going to go in with our nasal endoscope for visualization, and then place the tip of this angiocath just medial to the middle turbinate. And vertically, you're probably going to go in about halfway from the bottom of the turbinate up to the roof of the nasal cavity. And you just need to advance this in a little bit into that space, and then you're going to inject the lidocaine through the angiocath. At that point, you're just going to move to the other side of the nose and do the exact same thing. Potential pitfalls with the injection. So one would be if you're going too low near the bottom of the turbinate. If that happens, you may end up where most of the lidocaine goes into the nasopharynx. If you go too high and too far back, you may be injecting out medial to the superior turbinate. And the superior turbinate will actually block the lidocaine from diffusing into the area of the sphenopalatine ganglion. But if you position the patient properly and you inject into that right area, the gravity will actually take most of the lidocaine to the proper position over the ganglion. Once you've done both sides, you just have to have the patient lay on their back with their neck extended for between 5 to 10 minutes to allow the lidocaine to diffuse into the area of the ganglion. So that's how we do it. The next question is, how often should you do the treatment? My protocol at this point is to perform the treatment once and then see the patient back 1 to 2 weeks later. And at that point, you want to get an idea of how well they've responded. And there's kind of three main groups. So one group will be people who respond very well. Either they've had no headaches at all or a huge improvement in their headaches. Group 2 are people who are sort of minimal to lower responders, where they get some improvement but not that much. And then group 3 will be people who have no improvement. So you're really looking to identify those dramatic responders, and those people are going to be coming back more and more to have this done. Usually what I'll do for people who respond well, or the more minimal responders, would be to have them get the treatment either daily or most every day for a 5-day period and kind of see what we get from that. And you may be able to get some better responses in those kind of minimal or mild responders by doing things more frequently. At that point, you're going to have a discussion with your patient and kind of see if they want to continue having the treatment. And then it's just sort of a matter of finding out the right frequency for each individual patient. I've had some people who get the treatment every 3 weeks, some people who get it once a month, some people once a week or every other week. It's just really up to every individual patient how often they want to get it. And the nice thing about this treatment is there's really no serious complications, and I mean, it's rare to even have any mild problems, other than just the mild discomfort of having the treatment done. So I would encourage you to try it. There's very little downside, and there's actually a huge amount of potential upside for your migraine and chronic headache patients. So again, if you'd like to contact me with further questions, you can reach me via email. It's drevans@texanent.com, DREVANS @texanent.com. And I look forward to hearing your results. Thanks.